So there's now a whole bunch of other drugs that are being tested in follicular lymphoma, and they have some promising activity. There's a range of drugs. So ibrutinib, venetoclax. What's your take on some of these?
I think there's a lot of agents being tested in multiply relapsed indolent lymphomas with modest activity, and that brings back to the issue that's been discussed. We need to identify biomarkers to select these patients, because as single agent, none of them probably will make it as a drug that would be approved based on single agent activity, with few exceptions. I think the exception is probably the EZH2 inhibitor, tazemetostat, which is actually used biomarker, which is the EZH2 mutations. Interesting that if you treat patients with EZH2 mutations in follicular lymphomas, you get a 92% response rate. Small number of patients, because these mutant patients not very highly prevalent. But even in the EZH2 wild type, you can see some responses, but it's a huge difference between the responses. You can see responses also better in the EZH2 mutant large cell lymphomas compared to wild type. So I think that's a beautiful evidence that if you select patients based on a biologic biomarker, you can take a drug that gives you 20, 30% response rate, make it 90% response rate. So venetoclax has activity. It's been very disappointing because it targets the very mechanism that it defines follicular lymphomas, BCL2, but the response rate was in the 20, 25%. So we need to find out, again, who are these patients? But again, it may not be good for single agent. Maybe these are good for combinations. So we need to find out what's the optimal partner for combinations and move them forward.
And in many ways, it actually surprises me at all. I remember when the first venetoclax data came out that there were, in CLL, there was these tremendous response rates. And again, I guess I was disappointed in follicular lymphoma that it wasn't higher. But, but the mechanism of action, I guess I would have thought that they really did need to be combined with other agents for ultimate.
I think that's the way it will be in the future, combination strategies.
Yeah, and it's going to be a challenge, right?
Just to build off of your comment, I think we shouldn't just combine things based on our prior experience and what works in lymphoma, particularly follicular lymphoma. So if we can be a little bit more strategic or rational about the combination, meaning focus a little bit more on some of the preclinical or the biomarkers that drive the combination, because I get a little bit frustrated when we just do these 2, 3, 4 drug combinations because, oh, well, they've worked before. Let's just build on the backbone. Because we have to consider cost, both in terms of financial, but also toxicity of the patient. So though combinations probably are going to be the most promising, we do need to be mindful of not just opening a study because it's a CD20, it's a BTK, it's a BCL2 inhibitor. They should all work if we combine them.
It's an interesting point with venetoclax. I mean, I agree 100% with everything that's been said, right? Ideally, combinations should be rational, not random. Interesting thing, venetoclax is one of the few drugs where it actually is a rational combination with chemotherapy, right? And even still, wasn't impressive when it was combined with bendamustine and rituximab in follicular lymphoma. We saw those data last year at ASH, and I mean, even when it's combined rationally, it's still a little bit disappointing. So, but there probably is a better combination out there, and we just have to find it.
Right, but the combination does mean that with chemotherapy, right? You need to figure out what mediates resistance. It's still a absolutely perfect target, BCL2. Everybody knows that BCL2 is important for survival. But the presence of a target, although it's required, may not be sufficient to predict the response. So you need to figure out what other mechanisms. There's a lot of indication that MCL1 can compensate, and then that's why everybody's interested in MCL1 targeted agents. Whether you can combine both within safety is a different issue, but we need to look at other mechanisms that can mediate resistance to BCL2 inhibitors.
I couldn't agree more with what you said. I think we assume that translocation drives follicular lymphoma with BCL2 translocation, but it appears that venetoclax is actually quite active in the diseases which have overexpression of BCL2, like CLL or mantle cell lymphoma. It is possible that in setting of translocation, the mechanism is slightly different, and that's why the response rate is not as high as we're hoping for.
I also worry from a drug development standpoint, just in general, how we are going to do some of these things, such as looking for these very small subpopulations like the EZH2 mutants. Right now, I think most centers don't standardly do a next-gen panel on their patients with follicular lymphoma. If they did, they'd find a very small group. Talk about expensive when you start developing new therapies for smaller and smaller subgroups of this. It's a challenge. It's a challenge.
It is a challenge. The good news is that there is now movement to accept these assays that are useful for clinical practice. The FDA just approved 2 assays within last week. one from Foundation Medicine, one from Memorial. So this is happening now, it's being applied to clinical practice. But I agree with you, when you have a biomarker or genetic alteration that is at low frequency and druggable, I think the next approach is to combine more than ones that feed in one pathway and hit them probably not just one drug, but two drugs, to enlarge the bucket or population within the biomarker.